We'll start off with a starter for 10. Palliative care has come such a long way from its medieval roots in terms of serving the dying and the poor. And way back in the 1960s, you'll all be very familiar with this character here, Dame Dr. Cicely Saunders, the original multi-professional team, a hospital alumna who then trained as a nurse and then as a doctor at St Thomas's, who was unashamedly reformist and separatist in the way that she wanted to develop a specialty that couldn't work, she believed, within the constraints of the NHS. And the model in which she envisaged and developed has been rolled out globally in the United Kingdom, in Australia, in the Americas, and across Europe. It's done incredible things, not only in managing the very distressing symptoms that people experience at the end of life, but also in terms of its multidisciplinary format of also focusing on the psychosocial, the psychological, the spiritual, and the existential issues that surround those individuals living with life-threatening conditions, and also, very importantly, the families who live around them. And then, naturally, it follows through the period of grief and bereavement. I think we have to be applauded for this. We've done an incredible job. But despite the reality that hospice is free at the point of delivery, at least in the United Kingdom, the reality that it's been accessible to all those who can benefit from it has been absent for so many individuals. Many years ago, I was on the Channel 4 Dispatches programme where I argued fervently that hospice and palliative care was offering an exclusive service to a social elite. And by any other words, that's privileged care to privileged people. And that word seems odd in relation to those who are living with life-threatening conditions. You know, we've just had a smattering of the minutiae of the very distressing symptoms that people can experience as a consequence of their illnesses. It's rubbish, and grief is rubbish. But the reality that some of those individuals will benefit from what we refer to as impeccable assessment and high-quality end-of-life care is associated with privilege in terms of how those symptoms are mitigated and how we can care for the family members who surround those individuals and then travel with them during that process of grief and bereavement. So for those individuals who are living with life-threatening conditions, the presence of palliative care, all that privilege, is associated with health gain, adding life to years to those individuals to provide them with the best possible minute, the best possible hour, or the best possible afternoon that they can possibly experience in order to provide quality of life. But the manner in which the specialty has developed and has been orientated and geographically placed has meant that a certain kind of patient, a certain phenotype of patient has entered that privileged space. So we're talking about people who live in materially well-off areas. We're talking about people who aren't too old. We're talking about people who have a particularly stable or conservative type of illness trajectory that's predictable, for example, cancer. And we're also talking about people who inhabit a certain ethnic identity, by which I mean white. So what is this word called privilege that I've been focusing on for the last couple of minutes? I mean, I understand it as being a benefit enjoyed by an individual or a group beyond what's available to others. And at the heart of privilege and privilege theory are a series of unearned advantages that many of us just come across by accident or fortitude. And I often say that I went to a sink school in inner London. It was a dreadful comprehensive school, but I was surrounded by other material advantages that put me in the place that I am here today. If you're familiar with privilege theory, you're going to be familiar with Peggy McIntosh, who was a scholar from the States, and she refers to this kind of invisible backpack of currency that many of us accumulate through our lives that we aren't even aware of for the best part. And when she examined her backpack, she identified at least 24 individual items that she felt that were worthwhile putting on the table. For example, she could turn on the television or open the newspaper and see people mostly of her ethnicity, or that she was never asked to account for people in her group. Some of you might be familiar with this chap. He's David Roy. He was the editor of the Journal of Palliative Care. It's a really interesting palliative care journal because it doesn't just focus on the kind of Journal of Pain and Symptom Management, heavy-duty papers around symptom management. It also has quite a creative spin on it. It's got some very interesting poems as well as narratives. And 20 years ago, David Roy is actually unfortunately now dead. He wrote, "There probably aren't too many of us in well-organised hospices or palliative care programmes who have much extensive first-hand experience of how the poorest of the poor and those who are socially utterly marginalised live and die. Do we really want to know?" he asked. And that knowledge might be incredibly disturbing, loaded with an imperative that we actually have to do something. And I think we've come to a very interesting junction in relation to palliative care. We've just come away from the EAPC, where its focus was on inequality and inequity. And we've moved from a position where the American poet Ella Wheeler Wilcox said, "To sin by silence when we should protest makes cowards out of men." So we've moved from that position, and I'm very grateful for it, but there is such a distance to travel. Several months ago, football pundit Gary Lineker was incredibly vocal with his words and actions in relation to immigration policy. These are some of the very stark images that we've become almost immune to, and on the far right side is the ship that capsized off the coast of Greece. About 500 people have perished with that. And we know that throughout history, people have migrated from different countries for a whole host of different reasons: to escape war, to escape colonialization and domination by others, to escape genocide, to escape famine, and we're going to see much more of that in relation to climate change. People have escaped political torture, and also, quite reasonably, the prospect of education and social advantage, or the possibility of reuniting with family members. And the numbers are phenomenal. But I ask you to look at a street, almost any street, in order to understand demography. And this is a road that Fliss and I knew very well. This was the Peckham High Road, very close to where we worked in South East London. And what Sue Hall, who's a demographer at the London School of Hygiene, very elegantly did, was to map the geographical origins of the shop owners along this 30-mile stretch of road. And this is very interesting to understand, how do these individuals relate to life-limiting conditions, or the symptoms, or the grief, or how do they relate to health services? Each of them comes with a very different narrative, a very different lens, a legitimate lens for how they potentially comprehend the inexplicable. And then we need to ask ourselves, how do we accommodate them? What are we doing to provide them with a privileged care and privileged service at the end of life? So some of you might also be familiar with Professor Catherine Sleeman, who's at the Cicely Saunders Institute, who gave a talk at the Royal Albert Hall a number of years ago, where she focused very much on the reality that death has 100% prevalence. That's the first inconvenient truth. The second inconvenient truth is the manner in which we live with life-limiting conditions and die and grieve will be determined by all these social determinants of health. The dice are loaded, and they're not loaded in many individuals' favour. So let's start off with pain. Death will discriminate in relation to the management of pain. And we know from a great deal of studies that I've done over the years, and if we focus on pain in particular, that pain is a common symptom associated with advanced disease, and particularly cancer. Its prevalence can go up to at least 94% in the most advanced stages. And yet we know that there are very elegant strategies to manage pain. Pharmacological agents, for example, opioids. Opioids are a quality marker for the management of pain. And yet there are an increasing number of studies, more evidence that those from ethnically diverse and minoritized communities relieve sub-therapeutic doses of opioids to manage their pain that leaves them in distress. We don't know very much about this in the United Kingdom. What we do know is that from the National Cancer Patient Experience, people from minoritized communities are far less satisfied with the way in which their pain is managed compared to the normative population. We are in the process of the last several months of a study which is making use of big linked data, examining community prescribing for the management of cancer pain across different ethnic groups and its relationship to health service use. Early findings suggest that there are material differences, but I think it's worthwhile to potentially invite me back in a year's time where I can give you some really reassuring answers about whether there are differences and where we can potentially go with that data. So let's move on to another very important facet, which is in relation to where people want to die. This was a study conducted a number of years ago, making use of a telephone poll, and most people given the choice would prefer to die at home or in a hospice. The least preferred locations are institutions, for example, hospitals or nursing homes. So this was a statement put together way back in the early 60s by the foundation crew who were there to develop the hospice in Laurie Park Road. This was the hospice headed up by Dame Dr. Cicely Saunders. In hospice care, there will be no barriers of race, colour and creed. But what's the reality of that? This is a study that was conducted in the States of 200,000 individuals with head and neck cancers, and they wanted to examine social factors in relation to place of death. And what they found was that those from minoritized communities were far less likely to die in what we understand to be the most preferred locations. If we come back to this country, I conducted a study using big link data of 94,000 deaths across London over a 10-year period. Unfortunately, because of death registration records, we could only focus on those aged 65 and above because death registration records only contain country of birth and place of origin, not self-assigned ethnicity. That changed as a consequence of the pandemic. But what we did discover was that those from certain minoritized communities were far less likely to die in the preserve of that wonderful institution called a hospice compared to the normative population, the reference group. Shame on us. So, this is a nice systematic review, which again focuses on a number of different issues. Again, there's a very deficit approach in relation to who is getting what. Individuals are lacking awareness about what might be present and how they might benefit from it. And this is another systematic review, again demonstrating that those from minoritized communities are far less likely to benefit from high-quality end-of-life care. I think one of the problems, though, is that it's all about deficit, and I'll get back to that in a moment. I think no talk about privilege and high-quality end-of-life care, which should be equitable, would be missing a trick if it didn't focus on the pandemic. The pandemic was an extraordinary period in time which put services under enormous strain, and NICE put together some very useful guidance which suggested that clinicians should put patients in a position where if that person will recover, they would recover to an outcome that was acceptable to them. And very importantly, clinicians put together guidelines together under enormous pressure and time constraints in order to work out which individuals they considered would be fitting candidates to escalate to ICU and to ventilators. But when this crew here, who published in JAMA, examined the clinical records of those individuals, they discovered that many of the individuals who were rejected from having their care escalated to ICU inhabited materially deprived areas where the proportion of people living in those areas were particularly coming from ethnically diverse and marginalized communities. As a consequence of that, they were denied care at a really important moment in their lives. Similar work took place here in the United Kingdom by Claude Chidiac, and they discovered when they were looking at the first 60 patients to be referred to palliative care and then compared them with 60 patients from a period 12 months previously, those from minoritized communities were, well, there's quite a long delay in relation to them being referred to the team by about 5 days, for reasons which are very poorly understood. And that meant that was 5 days where they weren't benefiting from impeccable assessment, high quality care, looking after the family, and so on. We did some work with the Koffman study, with Sabrina, who headed up the study, with Jamila Hussain, who many of you know, and of course Fliss, who's in this room, a survey of around about over nearly 300 people. And we asked them if they were caring for patients from minoritized communities, if there were any differences in the care that they were providing to those individuals, and what were the challenges. And it was a very deficit-laden model in relation to what was being done. They stated very explicitly that they were providing an equal service, but Palliative is bespoke in terms of what's required by that patient and their family at that point in time. They have very different expectations. They misunderstand the role of palliative care. This is very deficit-laden in terms of thinking carefully. Perhaps we as the specialty have fault, and we need to reconfigure in terms of providing high-quality care to those individuals at a critical moment in their lives. I have been guilty in relation to the prolongation of this deficit model. I've looked at demographic factors that are associated with awareness of palliative care here in the United Kingdom, and also with Sarah Davison in Canada in relation to patients with end-stage renal failure. And what we've always discovered, if it comes up, is that people from materially deprived areas, people from ethnically diverse communities, don't understand what the specialty is all about. They don't understand what hospice is. They don't understand the role of Macmillan nurses. And I've got it wrong in relation to how we have ruined the panorama and how we should potentially be asking different questions. This is Katrina Maylan's work, which focused on bereavement care, systematic review that came out fairly recently. And again, if you look at her findings and her very elegant figure here, it's all about deficit in terms of not knowing, not being aware, not understanding, not coming forward. We need to change that narrative. And those red boxes indicate the status quo needs to change. My sea change came in relation to several key events. Firstly, Empire Windrush in relation to the reality that people who came here after the war to work in this country, to work on the underground, to work in the health service, were told many decades later that they weren't British and they needed to leave the United Kingdom rapidly. It also came in relation to the murder of George Floyd in the States and the growth of the Black Lives Matter movement, and also the pandemic in relation to the disproportionate impact of the pandemic on those from marginalised and minoritized communities. And when I presented something similar at the Palliative Care Congress, Gurpreet Gupta, who's a palliative care physician in North London, said, "Why did it take you so long?" And that's a very important question that I've had to ask myself, and also of the researchers working in the specialty. Why has it taken us so long? So we wrote an editorial, this is Sabrina Bajwa and Jamila Hussain, where we came out quite explicitly, based on the back of evidence, because we are evidence-based scientists, and stated that palliative care is inadvertently racist. Yeah, we stated that. It was very brave of Catherine Walsh to print our editorial. And one of the recommendations from our editorial was that we needed better science. So we then did a systematic review, which has just been published in the equity issue of Palliative Medicine, where we dissected the science of 109 papers and discovered that mostly the manner in which we've been doing research is inadvertently racist. The questions that we've constructed have been my questions or my colleagues' questions. The teams in which we have worked around have largely come from a white privileged background. The methods that we've used may not have been fit for purpose in terms of addressing those very important questions which weren't derived from the very communities that we wish to serve. And the manner in which we reported our findings lacked precision and also that very important word called respect. We can do better. And if we examine the workforce, again, who is working in palliative care? Who are occupying the positions of influence and power in terms of levering changes that will make a difference to those individuals at a critical moment in their lives and the families who surround them? Mostly white. And there's a survey that's been put together fairly recently, which has come up, and I think it was presented at the EAPC, which has presented some very cogent findings that the status quo needs to change. So, same old, same old. I wrote this for Marie Curie in Public Health England a number of years ago. It was based on a systematic review that I did with Natalia Canzani, who's based at the University of Cambridge now, and also analysis of big link data. And we put together 14 recommendations. Most of those recommendations are about lack of awareness, poor knowledge, hard to reach populations. And the idea is that if we just speak louder, then they'll come. My youngest daughter, Rachel, is very into this singer called Sarah Bareilles, and she's got a great song called Brave. And I think we do need to be brave and creative in the way in which we are reframing the science around palliative care, and also the manner in which we're engaging with people who, for a multitude of very important reasons, haven't engaged with a specialty which has considerable added value. Which is where we come to these very important words, and I've nearly finished here: cultural humility. And I think the word which I like more than cultural sensitivity and cultural competence is around cultural safety, which I think needs to be harnessed under the banner of clinical governance. How can it be safe for people to be poorly medicated at the end of life in relation to pain, particularly because we have very important data from Leslie Henson, who was based at King's, who analysed data in relation to ED attendances and discovered that people from minoritised communities were more likely, as a consequence of a crisis at home, to be admitted to ED in the last 3 months of life. How can it be safe not to provide equitable bereavement support with the knowledge that if bereavement is handled badly, it leads to complicated or prolonged grief, and in some instances, mortality? How can it be safe not to engage with people around ceilings of care and advanced care planning? So I think there are some solutions out there, and we were certainly presented with a couple of them at the APC, which was timely. I love the work by Alan Kelleher in relation to that interface between public health and palliative care and health promoting palliative care, and certainly the work by Libby Selno in relation to the Lancet's Commission on the Value of Death, which is seeking to redraft the agenda, find new bed linen in relation to understanding the value laden which is present in communities and engaging with that in a more meaningful way. It is us who are difficult to access. It's us who are difficult to engage with and understand. And we're not seeing the enormous value which is present in the communities out there in terms of social capital. So I didn't want this to be a negative talk. I see this as being a very exciting junction in the road in terms of how we could be the better specialty and use that position of privilege to lever changes that matter. Thank you ever so much.